We approach the room and they're doing CPR on this kiddo. And instantly, I have not felt this in a very long time. And instantly, because I felt deep in my heart, I already knew the outcome. And I walked into that room and I immediately was holding back tears. And I can't tell you how long since I've had that feeling. I walked into that room and I saw that kiddo and I was like, that's my kid in a couple years. Like I physically saw my child laying there. As you mentioned, the hair looked the same, the size looked the same, and I immediately connected. All the training and education and experience and pediatric readiness that I had went completely out of my brain for 0.2 seconds.
This is A Silent War Within, the podcast dedicated to confronting the unseen mental health battles carried by our first responder and healthcare heroes. This show is about real stories, real struggles, and real ways to survive the storm and come out stronger on the other side. For too long, stigma has kept you silent, but this is your space to bravely break that silence, share vital insights, and build a community where your well-being truly comes first, because your service deserves unwavering support.
Welcome back again, everybody, to A Silent War Within. We are so excited to have our guest today, and of course, Makayla is joining us. Makayla, how are you, our co-host?
I'm wonderful, Kevin. Thank you.
Good. We have had a great week. We had a great holiday season. This is the first time that we're actually getting to record. Of course, you guys know that we stay a few months ahead of our recording schedule, but this is the first time in about 2 weeks we've been back on. So if you hear any rust, just know that this was recorded first part of January when we were right out of the holiday season, and we all kind of took some time to decompress a little bit, which I think is important. But today's guest, who I'm extremely excited about, who I've followed for a while, who does kind of the same line of work that I do, so that excites me. And listening to him talk about pediatrics is amazing. You guys likely know him as the Blakery content. This is Christopher. How are you?
I'm doing well. Thank you so much for having me. I've been looking forward to this, so let's get into it. I appreciate the invite.
Oh yeah, we're so happy you accepted. We've been so blessed, overwhelmed to have everybody that we've reached out to really have just a positive response. When you start talking about anything mental health related, I was really expecting people to shy away, and it's been the exact opposite response from most people.
Yeah.
Literally all of our guests have been itching to get on and really excited about what we're doing. So I appreciate you saying yes. So the first part of the show is always kind of generally the same. I want to hear your story. I love people's stories. I love to know where they come from, how they grew up, how you got into EMS, healthcare, whatever your background is. So tell us that whole spiel.
Okay. Yeah. I'll give you the kind of long-winded story of Christopher Blake. So I grew up in a small town in Ohio, and I grew up in a 2-parent household. My parents worked, both of them worked full time, and I remember getting to the age where I would be home alone, and they worked full-time jobs, and I'd go out on my bicycle and spend the day at the pool all day at the local park and just did my thing. And as I grew up, I remember in grade school, we did a tour to the fire department. Still to this day, I can very vividly remember that tour to the fire department. I could smell the fragrance in the fire station. I remember the guys sliding down the pole. I remember them putting on their gear, showing us what the mask and SBA and all that stuff was. And I was like, this is incredible. Just in grade school, right? But I can still very vividly remember what that smell and experience was like. And then, time went on, and you get this like kid mentality of I want to be a fireman when I grow up, and so it stuck in the back, but it never felt like a reality. And I wish I could get my hands on this videotape. I remember in 7th grade with the old VCR camcorder, my 7th grade teacher going around the classroom and recording everyone desk by desk of what do you want to be when you grow up? And it got to me, and I said I wanted to be a fireman. I wanted to be a firefighter. And I wish I could get that recording, and because everyone was saying doctor, lawyer, fireman, police officer, and all the cool things at the time in middle school. But again, it never felt like a reality that I could actually do that. So I started straight out of high school. I was a lowest end manager, supervisor you could be at Staples, doing like electronic stuff at Staples. And one of the guys working with me, his dad and his stepdad were both firefighters. And we had a conversation one day, and I was like, "Oh, yeah, that's always been my dream." And he was like, "I can hook you up. I'll set you up with a ride along." And I was like, "Really? You can do like that's allowed?" So I went and did a ride along with them. And I rode along, and our first call was overdose at a hotel. And we got there, and I was like, this
You're
is it.
hooked.
This
You're
is
hooked.
it. Like
Yep.
this is where I'm supposed to be. And from that moment on, I started out again, like going through that process, like I just wanted to be a fireman. I just wanted to put the wet stuff on the red stuff, and I just wanted to fight fire and do that stuff. And when I got that introduction, it was the EMS side. And so went to EMT school. While I was in EMT school, I met a good buddy of mine who is still a very good friend of mine today. And I was like, hey, we lived in the same district, same fire department. And I was like, how does one even go about getting on the fire department? And he was just one of those guys, like his response was like, just go talk to the chief. Just go talk to him. Like, very distant and short. And he's still that way today. But I went and talked to the fire chief, and the chief's like, listen, if you finish EMT school, I will hire you. I'll put you through fire school, and I'll put you through paramedic school. And I was like,
Deal.
okay. Yeah. So, so I finished EMT school and quickly got on the fire department and started running volunteer slash part-time paid at this very rural township department that covered 36 square miles, and started going, working with them. And still, like, I was in my mind, I was like, I just want to be a fireman, but this is the route you do to be a fireman. And I started running calls. So obviously, as everyone knows, EMS is the biggest majority of what we do in the fire service. And I started falling in love with the medical side of it, the 911 side, the EMS side of it, because we were doing that a lot more. But I felt very restricted because oftentimes I was just driving. I got put up front and wasn't able to be in the back and doing patient care. And that motivated me very quickly to go on to paramedic school. Now, at the same time, while I was transitioning from EMT to paramedic, I also started working in the hospital and was doing like in-house transport, and they almost didn't hire me as an EMT because they're like, you're overqualified, you're going to be bored. And I was like, no, I'll be fine. 6 months in, I was bored, and I moved to the ICU as a tech. They called it a unit assistant. So basically, this is back when doctors wrote their notes on paper, and you had to transcribe what they wrote and enter it into a DOS system and fax the meds to the pharmacy and do all
Wow.
that. Yeah. So that's how old I am. And so I started doing that. And while I was going to paramedic school then. So while I was actively falling in love with the 911 side of responding to these emergent scenes and dealing with that, I was also actively falling in love with the critical care side of it, the ICU side of it, of seeing what happens once I drop that patient off and they end up in the ICU. And the nurses were phenomenal. They're like, every chance they got, they pulled me into the room and they were like, hey, I got an open belly. Come look at this. Come help me change this
Wow.
dressing. And then as I progressed through nursing school, the nurses were like, I can't get this IV. Can you come in and take a look? Right. And it just progressed. And in that moment is when I was like, I've got to fly. I want to fly. I want to be a flight nurse because I get to do both worlds. I get to
Wow.
respond to the scene, but I also get to deal with these critical care patients. At that time, there was only one program that was running the show in the area, and they fly advanced practice. So they fly a physician or nurse practitioner and a flight nurse specialist. And in that moment, I was like, I'm going to nursing school. There's no choice. I'm going to nursing school. And it took me a very long time to get there. I went in every direction but nursing school. I was like, I want to be arson investigator. So I went and did all the arson investigation stuff, got on the county arson task force team. I was like, oh, I want to do hazmat. And went and did all the hazmat classes and became on the county hazmat team. And then I was like, I want to be an educator. So I started getting all of the instructor certs that I possibly could. And I did that because I was a terrible public speaker. And I just dove into it because I was like, I suck at this. So I'm going to try and do this to overcome it. And as I'm going through there, and then I finally got to the point where I'm like, I know where I want to be. Why do I keep putting it off? So eventually I was like, I'm done. I'm going to nursing school. And I did it. And in the middle of all of that, so I would say just prior to starting nursing school, I had some peds calls at the fire department where this is where that pucker factor all starts. And I had a couple calls at the fire department. I was in my 20s. I didn't have kids. I didn't want kids. I didn't know how to talk to kids. I didn't know how to take care of kids. And so in the state that I live in, there was a point that we voted to take smoking out of bars and restaurants. And when that vote went through, I said, because we used to have like smoking sections and non-smoking sections in restaurants. I was like, when we make that transition, can we do kids, no kids? Because I was that person. I was that irritated by kids.
Yeah,
And
that's her.
yeah,
That's
and it was
totally
like,
her.
yeah. And so that was me. And I had a couple peds calls that just gave me that pucker factor that I showed up and I didn't know what to do. And I didn't like that feeling because up to this point, every time I didn't feel comfortable, I dove in and made myself feel more comfortable. I got the education, I got what I needed so that I felt more confident, but peds just was not it. And so I really struggled with that for a while. And I started diving into every pediatric class that I could and somehow ended up so I started out at the regional pediatric hospital as one of their in-house transporters. And I did that for 6 to 8 months. And I went to the manager and I said, listen, I said, I got to be honest with you. I said, I really thought that I could do this. I said, but I'm struggling. I'm bored. And I'm transitioned to the transport team as an ALS medic. And within 6 months of that, the critical care nurse manager was like, we'd like to bring you over and start cross training you for the critical care flight team. And I was like, there were so many people ahead of me and it ruffled some feathers. And I went to the people that were close enough to me and I was like, hey, like, this is what was offered. And they're like, nope, do it. Like, you deserve it. Like, go.
Yeah.
And so I was like, all right. So I went for it. And then within 8 to 10 months, I was transitioned over full time with the pediatric flight team as a medic. And that's where I transitioned to nursing. And then, I mean, I left once I was doing that. I flew for 4 years as a pediatric flight medic. And then straight out of nursing school, I went to the pediatric intensive care unit. I did that for 14 months. And then I still wanted to fly with the program that drove me to be a nurse. So I went to that hospital and I worked in their level 1 trauma ER. I did that for a year. As soon as I hit a year, I went to the surgical ICU, trauma ICU, and I did that for a year. And immediately after that, there was a spot that, like, right when I hit the 3 years required as a nurse for CAMES, a spot opened up on the Lifeline team. And I was already in connections and having talks with them. And I texted them. I was like, is this position real? Or are you guys like moving people? And they're like, no, it's real. Apply. And I applied and
Nice.
I got hired with the program that was the whole reason I went to nursing school. And that's kind of where I'm at now. There's some stuff in the middle there that I had to step away for a little bit. I actually left that team after a year because family happened and life happened. And I put my kiddos first, which was very hard because it took me 14 years to get there. and I was
Okay.
there for a year, and I walked away from it. I walked away,
Mm.
and, they told me that day, "We better be the first call when you're ready to come back," and I am now back there, and that's where I work full time.
Good.
So
Good. So
that is a long, long story,
no,
but I
no,
think it
I
all
absolutely
kind of
love that.
fills in with how I got to where I'm at and why.
And I've heard parts of this before through your lives and other things that I've been a part
Yeah,
of. But one of the things that really resonates for me about you is the fact that mine and your story are very similar. I found something I was deathly afraid of and had the pucker factor, and I was like, I don't want to be that guy because I adult patients just didn't bother me, just didn't scare me, didn't
right.
have a problem. You give me the worst one. But there was something about kids that just made me just draw up on the inside like something was going to break.
Yeah,
And I decided to go to a pediatric team and conquer my fear, and I did. And now I'm just as comfortable with some of them, not all of them. There's a few that
yeah.
still ruffle my feathers, but certainly different going to a team that specializes in pediatrics coming from an EMS background, and I absolutely have always loved that about your story. Since one of the first lives that I watched, you talked about some of your background, and I was hooked from then on. So you've had me as a fan for a while, so
I appreciate that.
I'm kind of fangirling to have you on the podcast.
I love that. Yeah, usually the part that I left out here, but that I usually say is that somehow I ended up as a pediatric and neonatal critical care flight nurse medic with 2 kids that completely control my life, right?
Yeah.
And, yeah, so it's come full circle, that is for sure.
I mean, same. I have a 5-year-old that was just knocking on the door behind me wondering what daddy's doing in here. So
Yeah. Yep.
so absolutely. Even though he knows, he
Yeah.
wants to be in here watching.
Absolutely.
So Makayla, you can go
You
ahead with
should let him come in. You should
absolutely not.
let him come in. That would make for a very interesting episode. I would love to see his
Right.
Interesting
questions,
indeed.
honestly.
Yeah.
Alright, so for all the people watching that don't know what that pucker effect is, kind of explain what that is, what that means, and, like, what that means on a regular call.
Yeah, so right, so when that pediatric call drops, our body reacts before our mind ever catches up. And for many medics, there's just this instantaneous adrenaline dump. It's that primitive survival response driven by our brain recognizing that these are high stress, these are high stakes, high emotions, and there's low margin for error in our pediatric patients. And this is something that even our seasoned providers experience. And as Dr. Antevi speaks about, making the 30-year veteran feel like a brand new probie on that call because it's just not something that we see a ton of. And basically our bodies just dump. We're flooded with that epinephrine and cortisol, and our heart rate spike, our breathing becomes fast and shallow, and our hands start to tremble, and we have a hard time holding on to things and doing the gear and things that we typically do all the time on these adult patients. It just changes for us when it's pediatric patients, and our vision narrows. We get that tunnel vision of focusing on specific tasks instead of that bigger picture, and ultimately comes down to what I feel is lack of confidence and lack of training and experience.
So, what is one thing that when you walk onto a scene with the kid, what is one thing that will immediately make your blood pressure go through the roof?
That's a good question. I think honestly on still on every pediatric call, my heart rate still goes up. My blood
Mhm.
pressure goes up. I still get nervous, and I'm assuming we'll at some point this will come up, but I just recently had a trauma arrest on my last shift that's sitting pretty heavy with me. And I was kind of looking forward to this dialogue and conversation because I figured it would kind of come up. But
Mhm.
I think that every pediatric call still makes my heart rate go up and still makes my blood pressure go up. And a lot of my videos start out with, do you get nervous when you have to do this? So do I, but let's talk about it. Right? Like my
Yeah.
heart rate's still gonna go up, but my brain has a plan. I know the
Mhm.
stress that comes from it goes to a better place. I have a place for it versus blah, 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 right? Like, of where I'm just of where it's just like, I don't know what to do. Like, I'm still on the inside, my butthole is still puckering. I have
Yep.
that pucker factor and I'm still nervous, but I'm able to control it and I'm able to manage it because I'm a little bit more confident. I'm a little bit more experienced. I'm a little bit more comfortable, but I'm still nervous. I'm still human. So I think every pediatric call still gets that spike, but I know how to manage it better.
Now, for people who are like me, who before me and Kevin even started this podcast, the world of kids, the sick ICU, the trauma ICU, burn ICU, all that is still very far removed from my knowledge.
Okay.
I do float pool, I do inpatient nursing, I go to the ICU, I only take step down holds, things like that. So, but even before me and Kevin started this, I didn't really know about like the difference between a kid's call and like an adult call. To me, they were all the same. So, for those people who don't know, what makes a kid's call so different? Do they just go bad faster? Is that what it is to you?
Well, I think there's a couple things to that, right? So one of it is lack of comfortability and lack of education and readiness because what we basically when we are educated as paramedics, most programs and one of the things I talked to Dr. Antevi about recently is there's a program in this area that has completely changed this completely. However, most paramedics go to school and they're taught adult respiratory, adult cardiology, adult everything, and then there's this small little window that it's like, oh, hey, there's also pediatrics and neonates and OB, but they're gross and you won't get very much of them and nobody's comfortable with them. So here's a little bit of information about it and moving on back to adults, geriatrics, and
Mhm.
whatever. So there's this small little portion. Now, what a program in my region has done and what Dr. Antevi advocates for and is doing with his programs, he has taken away the pediatric protocols completely. They're combined with the adults, and that's the education that this paramedic program is doing is that if they're talking about respiratory, it is adult and pediatric respiratory. It's all in the same category. Cardiovascular,
Fantastic.
adults, pediatrics. This agency, this paramedic program has partnered with a regional pediatric center that I previously worked at. We worked together. Now, those students are doing more than 60 hours of clinicals at the pediatric regional center. They're doing time in the emergency department with a nurse. They're doing time in the emergency department with a physician. They are going to the PICU. They're going to the NICU. They're going time on the transitional care unit, like the STEP unit with all the trach vent patients with a respiratory therapist. They do 60 hours over the entire curriculum to make sure that it is embedded throughout the whole process and that pediatrics is not just this small little picture or window within their program. And that is very rare. I don't know of any other programs
Mhm.
across the country that are doing that. This pediatrics is this very small window and it's just like so statistically across the nation, pediatrics are less than 1% of the call volume for most EMS agencies. So they don't do a lot of it. So most instructors are like, I'm not comfortable with it. So I can't teach you. You'll be fine. You're not going to see much of this.
Yes, that statistic is accurate, but I think where that fails is like, and you're probably dealing with some of this right now. I deal with it on a regular basis. There is so much more personalization to a pediatric call than there is any other call. I think you see
Yeah.
your kids, your nieces, whoever you're close to, you just personalize that person. I think that's what hit me so hard with my pediatric drowning that kind of catapulted my career into pediatrics is that I saw my daughter. I saw a kid that looked like my kid, was
Yep.
the same size. Even in my presentation that I presented, numerous times throughout the Mid South now, I go through and list all the things that was happening in my mind and body throughout that process. Like this kid's hair reminded me of my kid's hair. It's all the
Yeah.
little smells, it's all the little sights, it's
Yep.
everything combined. And with adults, because 99% of the calls are adults, we have learned to filter out a lot of
Yeah.
that personalization. We don't see grandma, or we see 55-year-old and we think, oh, they lived a pretty good life. I mean, they got kids, a wife, and we kind of shoo those feelings away. But with a pediatric call where it's so different is you can't just silence what your mind is saying, because naturally kids are not supposed to be sick. Kids are not supposed to
Yep.
be hurt, and kids are not supposed to suffer. So when we see it that in that 1%, it is one of those things that lays heavy on our hearts, as you said, and lays heavy on our minds for
Yeah.
days after. It's not something that we can just go, man, that sucked, and just move on.
Yep.
With bad adults, a lot of times we fall into the category, and this is not a healthy coping mechanism, of course, but a lot of times we've been conditioned to go, yeah, that sucked. That was pretty bad. Let's move on to the next one. And there's usually another one waiting. But with a
Yeah.
pediatric, like your brain is a hard stop. Like it's personalized. You can't get through it. You can't get over it. It's just one of those things that just sticks with you. As pediatric providers, I found that as a whole, we're really bad about going back and thinking through every single detail of what we did. And we find ourselves, could I have gotten that IV quicker? Could I have intubated with a different mechanism? Could I have used a bougie? Could I have used a video laryngoscope versus a direct vision? All those things just weigh heavy on us. And I think
Mhm.
that's, to answer your question, Michaela, the real difference is like there's just so much more weight to a pediatric call that I don't think people that don't do pediatrics understand the magnitude of.
Well, I was just gonna say, Kevin, I know that you probably would agree with this. When people get transferred from, say, the nursing home to the hospital, it's very rare that they have family with them or anything like that. And so it's very easy to treat that person as a
Mhm.
patient, you know. But then when mom and dad are there over this kid that they love so much and they're crying and, everyone's very emotional,
Oh, it's an
I'm
it's an
sure
entirely it's an
when you walk
entirely
into
different
that, it's a
dynamic.
different level.
Oh, for
And you
sure.
have to mentally prepare yourself for just that base level of emotions you're gonna get in that environment.
What I also too find is all the mental preparation work that you may do, like, this is gonna be bad, especially if you're going after in a transport environment like I live in, and Christopher, that you live in. One of the things that I find is we try to mentally prepare, and all the mental preparedness doesn't really prepare us for what we see when we walk in the door. Like we know what we're going to,
Yeah.
but when you walk in, there's still that little second of shock, and there's still that little second of, oh, look at those parents. And some of us have kind of conditioned ourselves to not see it or feel it in the moment, but
Mm.
afterwards, there's that heaviness that comes back on you. This perfectly transitions into the next part of what I wanted to talk about, and that mental pucker factor. Like that's there, that's real. And
It
it's
is.
so hard to explain into words, but there's just so much more there with peds. And Christopher, you can talk a little bit to this, and especially just having a recent call, I would love to hear what you're comfortable sharing about it.
Yeah, absolutely, right? I think there's a difference between the IFT side and the 911 side, right? In the fact
Sure.
that with the IFT side, we almost always know what we're walking into. And the transport team that I worked on, we were part of the triage call and the determination of transport. So we heard the doctor to doctor conversation or the report based on the patient. So we had a very good picture of what we were walking into. Now on the 911 side, you don't always get that. On the 911 side, it is the frantic call of a sick child or an MBA or whatever that may be, right? Car versus pedestrian, whatever. And that's what happened to me recently. Like I felt like, and I've made several posts about this recently of I was made very aware that I'm still a human being the other day. And the fact that I preach, like, my whole platform is about pediatric readiness and building confidence and showing up prepared and ready to do work. And then, regardless of the outcome, being able to walk away knowing that I gave that child every possible option at a better outcome. Now, I had one the other day that we didn't know what we were walking into until we were on short final, meaning we were about to land at the hospital that we were going to. I didn't know if it was a trauma, medical, adult, peds. I had no information. It was supposed to be a scene run, and we got diverted to the local hospital, and we had no information. And as we're coming in, we're about 20 feet off the ground, and they're like, be advised, this is going to be a pediatric trauma, car versus a bicycle. That changes things, right? Like, very quickly, it changes things. And you don't have as much time to prepare. You don't have as much time to mentally prep. I'm used to putting tape, 2-inch tape on my leg and calculating everything out. And I have all my doses ready and ET tube size and all the things I'm going to need are pre-calculated before I get there. And I had no information. I had no idea. And I'm walking into this blind. And this particular hospital was a very long walk to get from the helipad to the ED. And we're hoofing it. I mean, we are hoofing it to try and get in there. And as soon as and there's a line of people outside the ED as we go through them, and you can see all of them just looking at us as the flight team that just showed up out of nowhere and trucking through. And you feel their emotions, you feel their presence and them looking at you. And then you walk into the ED and you can see the look on all the ED staff face as they see you break through. And we approach the room and they're doing CPR on this kiddo. And instantly, I have not felt this in a very long time. And instantly, because I felt deep in my heart, I already knew the outcome, and I walked into that room and I immediately was holding back tears. And I have not done that. I can't tell you how long since I've had that feeling. And I walked into that room and I saw that kiddo and I was like, that's my kid in a couple years. Like, I physically saw my child laying there. As you mentioned, the hair looked the same, the size looked the same. And I immediately connected. And I was like, that could very easily be my kiddo sitting right there. All the training and education and experience and pediatric readiness that I had went completely out of my brain for 0.2 seconds to maybe a whole second, right? Of just that holding back tears of like, that is my child laying there in that bed, dead that quick. I went to work. And I did everything I possibly could to give that kid the best outcome, a different outcome that we could possibly do. And I'm very fortunate. The program that I fly with, we fly with a physician or a nurse practitioner. So we bring the ability to do more things to the bedside. And we were able to do those things. And I'll be honest with you, the most important thing that I did in that moment was wash that kiddo's face. That was the most important thing. I washed the kid's face. So when the family came to the bedside, the first thing mom did was kissed him on a clean forehead. And that was the most impactful thing that I could do. And I'm glad I did it. I'm glad I was there to do that because nobody else in the room did it because they don't see pediatrics and they were focused. They did a great job. The fire department did a great job. The hospital staff did a great job. And we did all the things that we could do. But at that moment, there was nothing else left to do but support the family. And that is such a huge part of pediatrics, and family-centered care is a soapbox that I will stand on till the day that I die. And
Absolutely.
I couldn't do anything else for that patient in that moment, but what I could do was support that family and make that situation that was absolutely terrible just a fraction better, just a fraction better. and support that
But
family.
I think one of the big things to take away here, though, is that many times we beat ourselves up because we don't have a good outcome. But everything that you said that you felt was natural and it was
Yeah.
human.
Yep.
And there is no shame. And I want everybody to listen to hear this. There is no shame in still having your humanity. You can have all the training in the world
Yep.
and you can be the most comfortable with every other patient. For me, I absolutely love an RSV kid that I know I can turn around, an asthma kid that I know I can turn around, some respiratory thing that I know that I have the tools that I can make a dent. But there are those that I have come across that, Christopher, you and I are on the same page. Like, there's the outcome before you start, and it's such a personalized thing when you do see your child. One of the first guests that we had on was Shade Tree Cardiology, Greg Carr,
Yeah.
who's an awesome guy. And he told a story of 10 years ago. He had a very similar experience. And, I think we all can go back and pick out calls from years
Yep.
ago or even as soon as you or as most recent as you, but we can pick out those calls where we personalize those. The fact of the matter is there's nothing wrong with being human. There's nothing
Yep.
wrong with showing that side and that emotion. And I think that the secondary pucker factor to this is not just that you see the kid and you see what's happening with them, but you also see the parents that are hurting, that have experienced loss,
Yeah.
that have experienced something totally unnatural because kids are supposed to bury their parents. Our kids are supposed to bury us. That's a natural occurrence. We are not supposed to bury our children. And so you do have kind of a moral injury that occurs from that because you're seeing something that is unnatural. You're seeing something that feels like it's inherently wrong. So not only do you deal with the emotions from seeing this child that you've personalized or kind of made your own and had to work hard and still didn't have a great outcome sometimes, but you also deal with the parents and you also see their hurt. So I mean it is really hard sometimes to go to those calls and to get back on the helicopter or to get back in the ambulance and drive away, not having a patient or not having the outcome that you preferred. So yeah, man, that's tough. Everything you described was taking me back to I mean, because I'm the 2-inch tape guy too. It's always on my
Yeah.
leg. I'm always prepared.
Yeah.
And there's been a few times and the drowning that I talk about often is one of them I didn't know it was a kid that was in cardiac arrest until I got there. And it was walking in blind. So a lot of
Yeah.
what you were saying, I was sitting here going, "I've been there." Yeah,
Yep.
it's inherently tougher when you're not prepared.
It really
It
is.
feels tougher, yeah,
Yeah.
yeah.
And Kevin, I also want to hit on one thing that a lot of people don't realize, which I think I struggle with, I know you've struggled with in the past, is anger too. You know, that natural anger that comes from having to deal with the guy who hit the kid, if he's
Mm.
drunk or
Oh,
whatever.
yeah.
Like, there's an innumerable amount, a numerous amount of anger that comes with those situations too. Your own
Well
anger, if you are not able to do something, let's talk about that for a minute.
well, for me, it was always the anger of it didn't work the way it was supposed to. When I intubate and I provide oxygen to people's lungs, it's supposed to work. They're supposed to have this recovery. They're supposed to do this. Or if I'm doing CPR and we get a pulse back, okay, we won. Well, not necessarily because you have so many other factors to think about after you get a pulse back. Or they might lose it again, or it might be a momentary thing. Like there's so much anger that comes from that sometimes that is also totally normal. And from an EMS side of it, it's totally normal to feel anger toward, and I can tell you, and you guys all know this, but I'm in Memphis, and we probably see, I think the last number that they put out was 2 to 3,000 child abuse cases a year. I mean, it's like a ridiculous disease down here. And it's very difficult when you go on calls like that or a drunk driver has killed a family to not feel that inherent anger. And it's natural to feel it, but you don't want to control it, but you have to. And it's the same when we have very negative outcomes. We have a natural anger that nature, God, whatever you believe in, has made some mistake somewhere, because this is not how this is supposed to work. So it's really hard to kind of navigate through that. Regardless of what your beliefs are, you kind of have to start to figure out what you're going to do to get around that. And really, this kind of dialogue and this kind of talking, and whether it be with a counselor or whether it be with peer support or whatever it is, this is the absolute best way to start to move through some of that and to get those feelings out there, and to have somebody say, and I've said it 1,000 times, but when I was in my mental health crisis where that drowning call had literally done me in, if I just would have had somebody to come beside me and say, I've been there too, it would have made all the difference in the world. Because when you're feeling all this stuff, it is such a lonely, lonely place. You feel like you're the only one that feels this way. And that's
Yeah.
just not true.
Yeah. For sure. And I think on my side of it, feel like I am able to better. So there were two things that were told to me very early on in my career. And this is early 2001 when mental health was not talked about in the fire department at all. Like it wasn't accepted, right? So like these were two things that were told to me very early on that have lived with me for this entire time. Is that one is understanding that you didn't cause the incident. It's not your fault that it happened. So you didn't cause it, and that you were simply there to try and make the situation a little bit better. Just a little bit better. Okay. So that was one thing that was told to me. And the other thing was don't hold it in. The more you talk about it, the better you're going to feel. So again, that was early 2000, well, late 2001, early 2002, before mental health and resiliency and all the things were accepted in the fire service. And this was a small rural volunteer slash part-time department, with a bunch of jolly volleys that have been doing it forever. Like those were the people that brought me up, and they were telling me these things. Like these were things that left an impression on me and have stuck with me forever, through my entire career. And I made a post on TikTok of the calls I had in the last 36 hours, because I did a 24-hour rotor shift off 12 and then a 12-hour night shift on ground. I did 5 flights in my 24-hour shift, and I did 3 ground transports, and they were all sick. It was intense. And I made a post about it. And somebody just, how there are people out there, and, mentioned that I was bragging about what I did in my day. And I was like, said, I gotta be honest. I said, I had a rough couple shifts, and I was soliciting some good conversation with peers, and just trying to have some dialogue and conversation around the things that I seen and that I'd experienced and did over the last 36 hours. And honestly, I started that comment with, "Are you okay? You good? Like, do you need to talk? Because I'm here if you need to talk." I was like, I'm not trying to take anything away from you, but I had a rough couple days and I needed to talk about it. And I was hoping for some support and just some dialogue, and even just simple texts and comments of being able to have conversation about the way I'm feeling. And I closed it out with, but like for real, like if you need to talk to someone, reach out. I'll chat with you, right? If I'm all about supporting each other and building each other up, and I went through some shit in the last 36 hours, and I felt very
Yeah.
strong going into those 36 hours, and I came out of them feeling just crushed. And I just needed to talk, and I needed to chat, and I needed comments, and I needed, if it's bragging, that's fine. But it opened up some dialogue and conversation and allowed me to chat with more and more people about what I went through. And that's how I vent. That's how I get it off my chest, because we got back from that flight, and immediately went out on another flight and got back from that one. And finally got to bed, and I'm not gonna lie. I mean, I'm 44 years old, and I'm a man, and I'm a nurse, and I'm a paramedic, and I cried myself to sleep in my bed at the station, and I woke up a couple hours later to go back out and do another flight. So if I'm soliciting some comments and conversation online, I'm okay with it. I'm okay with that.
I don't think there is any shame in saying that, because if you're a provider that has done any kind of emergency services, or even those who have done other lines of work within healthcare, there's always those patients that are just gonna get you.
Yeah.
And being busy like that
So
is, and especially with critical kids back to back to back.
so you know what? One of the flights earlier in the day was a 45-minute transport time flight, 45-minute flight time, and it was a 90-year-old stroke patient who was completely out of their right place. As soon as we lifted, so we got her loaded in the aircraft. As soon as we lifted, I could feel I could feel she was getting nervous. I could feel it. And I reached over and I grabbed her hand, and she held my hand as tight as she could possibly hold my hand. And I left my hand there. And I've said this before, one of the most often skills that I use as a nurse, as a paramedic, is just holding someone's hand. And she held my hand, and we were a few minutes out, and I had to do something, and I let go. This patient that was completely, not following commands very well when we got there, as soon as I let go, lifted their head off the bed, looked for me, found my hand, and grabbed my hand and pulled. And I reached back out and I grabbed her hand, and she pulled it back in and nestled it against her stomach and put her head back down and just rested the rest of the flight. So I had, I made this post of my calls in the last 36 hours, and it was these 8 calls, and they were very critical patients. But the two most important things I did out of that 36 hours was to hold a 90-year-old woman's hand and wash a child's face. Those were the two most important things I did in 36 hours. And they had more impact than any medication that I ever could have given.
Yeah, because those were heart actions and not medical actions.
Yeah,
Yeah.
Sometimes when we treat with our hearts, the
that's
outcome is much better.
And
I
plus, you
treated
brought up a
both of
really
them
good
with my
point.
hearts.
Yeah, well, I love that because I feel like that's the kind of nurse I am. You may ask me where the patient's going to rehab tomorrow, and I don't know. But if you ask me about their life and their family, I'll know everything about them.
Yeah,
But it's the heart, and a lot of people that get into nursing or healthcare or anything, and they don't have that heart. I feel like it it does show, and those are the people probably commenting on your post, and they're
yeah,
saying, you're just doing it for brags because they can't see that emotional part of it because they're not
right.
connected to it. And for people like us, us three that we really love healthcare and we really love people and we really love what we do, that's disheartening because
Yeah,
when they don't deal with their own trauma and their own stuff and they dig it down and push it deeper and deeper and deeper, it comes up in those ways. Like you get burnt out, you're mean to your coworkers, no one wants to work with you, things like that. So,
yeah.
what are some things that you personally do to combat that mental load? And what do you do to kind of take a load off yourself?
Yeah, so I think part of it is the readiness part. And part of that is preparing up front and having the knowledge and know-how and confidence of how to approach those calls and treat those calls. Because I think that, and Dr. Antemi and I discussed this pretty deeply, but I feel like when you walk away from a call thinking, I smoked it. I smoked it. Like I did a good job, right? If you show up, the calls that live with you and the ones that sit heavy are the ones that you showed up and maybe you could have done better. Maybe you botched something or something didn't go the way that you wanted. I feel like those are the ones that sit with you heavier. But if you are very instrumental in what you are prepared and confident, ready to go, and things go the way that you plan them to go, you walk away and you're like, I crushed it. I know in my heart of hearts that I gave that patient every ability and a better outcome. And I can go back and lay my head down and the outcome sucked. Absolutely sucked. But I know that I showed up to a situation that I didn't cause with a goal of only making it a little bit better, and I crushed it.
Mhm.
I think that is such a huge piece of it, a huge piece. And then when you walk away from it, right? And the situation, so this one the other, just the other day, I didn't get to do my things. Because by time we got there, we were already at a certain point. Now, the fire department rocked it, the ER rocked it, and I just got to help facilitate some of the ending part of it. Now, what I did get to do was tell the fire department, listen, you rocked it. And I watched a crew that showed up at the scene, dealt with the patient, did the things, got them to the ER, dropped them off. They didn't leave. They stood there and watched. They watched everything occur. And then the nursing staff and the physician staff that went in, right? And then as a flight crew showing up and looking at the eyes of the physician that said, here's what we've done. Do you have any suggestions? Like what else can we, and supporting them through that. And then what we did is we got everyone together and debriefed at the end. And I got to tell that fire department, listen, as a flight nurse and paramedic with X amount of experience, I had a plan in my head of everything I was going to do when I walked into that room. I didn't get to do any of it because you already did it. You already did it. You crushed it. You did a great job. I couldn't do anything because you already did it. Phenomenal. Phenomenal job. Right. And then you could see their stance shift. You could see the look on their face shift. I wasn't blowing smoke up their asses. Literally, everything that was in my mind of what I was planning on doing was already done. They crushed it. That is such a huge part.
And you know that I think that is such a when you get to an advanced provider level and you get to kind of where all these people around you are looking to you to be kind of the end all be all. And of course, we're not physicians. I'm not going in that direction. I'm just saying from an EMS guy, when flight used to show up, they were the people you wanted. Like
Yeah.
they were gonna take it over and they were gonna do the things you couldn't. But for somebody to say that from your level, that's so powerful. And clearly, my stance would have shifted too if somebody in your position came in and said, "You guys already did what I was going to do," and that's awesome. That is so cool. What do you say to those people who are kind of in denial that there's a difference and in denial that they need to learn this?
Yeah. So I will tell you, and we're going to differ a little bit here, is that I've spent most of my career educating people that they are not just small adults, right? As you said. But the more that I have been teaching and the more that I look in different aspects, right, of like tactical medicine and wilderness medicine, and I help teach some of those courses and ACLS and PALS, and the more you look at it, the treatment is the same, right? And the
Yeah.
algorithms are the same and the way that we treat them. So like kind of breaking down some of that fear of that they aren't just small adults in the fact of like and that's where that program that's teaching all of it together is I think is gonna change the game is when you can start to tie together. If I'm treating a pediatric asthmatic, my algorithm is the same that I'm teaching an adult. And now all of a sudden I'm
Mhm.
like, well, wait a minute. I know how to treat an adult asthmatic. Why is my butthole puckering? Because it's a kid. It's the same treatment, right? But that's
Yeah.
reality of it. Breaking when we
Yeah.
can start to break, and so Dr. Antebi talks about he no longer has adult and pediatric protocols. They are combined. They are one protocol. And now him and I agreed because my stance was, yeah, but their airways are different. And there's growth and development milestones and the doses are, but
Mhm.
okay, but that's like the 5% of it. So let's talk about the 90 to 95% that is the same and address that and reduce some of that fear around how we treat them, get that on lock, and then be like, all right, so here's where they are different. Here is what we need to think about a little bit differently. Because when I treat an asthmatic or I treat a PEA, or I treat an SVT, all the treatments are the same. Or an actively bleeding patient in an active shooter situation,
Yeah.
right? It's
Yeah.
stop the bleed. Tourniquets work on
Yeah,
kids and
absolutely.
adults.
Yeah.
So breaking down those barriers and taking away, and I have a T-shirt. The pediatric hospital I worked for has a like cutouts of kids, and it says, "Kids are not just small adults." And I've bought into that for a very long time, and on some facts they are not. But the more and more I go out and teach, I'm like, well, wait a minute, they kind of are small adults in the fact that, like, they're just smaller, we're treating them the same, but there are obvious differences. There are
But
anatomical
when you talk
differences.
about that, I like that approach. I like that approach that because
Yeah,
that kills some of the fear, that
it does.
95%. Yeah, I can totally agree with you that 95%, you're exactly right. And I think the little adults thing comes from that 5% of the differences,
Yep,
the difference in medications, the airways, the different things you have to do for the airway. Things like different things they respond to that adults might not necessarily respond to
yep.
as well. So yeah, I do like that approach. I have not thought about it that way, that 95% is really the same.
I didn't either until very recently, where I've started to change that mindset of, and then when I sat down and talked to Dr. Antavi and we dived into it a little bit more, and I was just like, all right, I think I'm sold on this.
Yeah, that's very interesting. I cannot wait to watch that. So tell us to kind of start to close out because we're at like an hour and 2 minutes. I could talk to you for a while, but so what's your goals for 2026? You've started off really strong. You got this podcast. So tell us about your podcast and tell us about what you're doing and tell us about Dr. Antevi and kind of how that went
Yeah, so
because I'm in on this.
basically the Blakery content was several years in the making, and like I said, I started out, I felt that pucker factor very early in my career, and that's the way that I knew that it was real is because I personally felt it. I felt my butthole pucker when I was going on a pediatric call at the
Mhm.
fire department, and I wasn't trained. I didn't have the confidence and I didn't have experience with kids. And I just started taking every pediatric class that I could. And the very first one was NRP. And the local hospital, I reached out to them because they had an NRP course and they're like, we have never had a paramedic take this class. They're like, we won't even, she's like, I won't even charge you. I would just love to have you in the class. And I was like, that's my kind of class. So
Me
I
too.
I went and took this course, and this is where I first learned they're putting babies in a bag, and they're doing all
Hmm.
these you know, they're telling me they're like, "Medics are great at delivering babies, but they suck at keeping them warm," and all these things, and I was just like I was mind blown because these were all concepts I had never been told, and I kid you
Hmm.
not, it wasn't but a week or 2 later I had my first delivery in the field, and I'll never forget it. We got dispatched out. One of my friends was the dispatcher, and she dispatched us out for a woman in active labor. And I jump in the ambulance and I call us in report or en route. And she goes, "That's clear. You're en route to such and such address for a woman in active labor." And she pauses and she goes, "Good luck." And I was like, so we show up and it just happened to be it was a full-term baby. It was mom's second baby. She thought she had to go to the bathroom and delivered on the toilet. And we walked in right as dad caught the baby. And we walk in and dad's panicked, mom's panicked, and I we walk in and baby is pink and crying and happy and we were able to go in and I took the baby. We can't or clamp the cord. We let dad come back in and cut the cord and be a part of that. And then I looked at my partner and I was like, I got the baby. You got mom. Mom still had the placenta and umbilical cord hanging out on the toilet. I was like, I'm out of here. And never in my life would I would have been like, I'm taking baby, right? Like, and I took the baby,
Right.
and baby was great. And you know what I did to that baby? It was full term. It was probably a little, but it was freezing cold outside. I took that baby, I warmed him, I dried him, I stimulated him, and I put him in a bag, and I kept him warm, and then I gave it to mom, and we showed up to that ER, and that ER was like, they took one look, and they were like, they were about to say something, and then they were like, okay, all right. They
Mhm.
this baby showed up warm, and that's what has driven all of this. I felt that pucker factor, and then I felt what it was like to feel confident and comfortable on that call.
Mhm.
And this whole platform has been around reducing that pucker factor for other providers in the pre-hospital environment, because I know all it takes is a little bit of education, a little bit of knowledge, a little bit of comfortableness and exposure. I've been called a pediatric expert way too many times. I'm like, I'm not an expert. I've just been exposed a little bit more than you have. That's it. And that is my whole platform. And that's the whole point of the podcast, is reducing the pucker factor, is interviewing high level pediatric providers that can break down some of those barriers for pre-hospital providers, and talk about the things that are important and can influence the care that is provided. And on top of that, my conferences, I've been traveling around to multiple conferences, and I have quite a few lined up for 2026, where I am presenting my Reducing the Pucker Factor lecture, about how we can address these things at the agency level and reduce that pucker factor for the providers by implementing some very simple changes. So, one of the other things for 2026 I'm looking forward to is I sit on the editorial board for the International Trauma Life Support Program. I'm not sure if you're familiar with that textbook and
Oh,
course,
yeah.
but
Absolutely.
we just rewrote the ITLS textbook from the ground up and self-published. It's available now, but I believe very strongly that I will probably be the point person or chair. If not, I will be a strong supporter of the point person or chair, to start rewriting the pediatric ITLS
Mhm.
textbook and course from the ground up. So that is coming as well. We are going to just hit that with the ground running, and get that textbook updated and out there to the people to address pediatrics. And one of my focuses with that has always been like pre-hospital driven. I think there's a huge lacking in, one, family-centered care, and two,
Mhm.
for the pediatric and neonatal transport team that is full of PICU nurses and NICU nurses that aren't familiar with the EMS world for trauma. So when they show up for a trauma patient transfer, they don't understand that rapid assessment and rapid transport. They get locked into that stay and play for an hour, hour and a half, as they do in the peds and NICU world. So that is
Mhm.
I think that may be a new chapter in this text and curriculum, is for the IFT peds team, on how we better manage pediatric trauma in that early stages. So those are some of the big things
Mhm.
that I have in 2026. I'm leaving in a couple weeks to present at a NAEMSP. So that actually it's AMPA, so the Air Medical Physician Association at NAMSP. And then I will be in Idaho at the Spring Fling doing my
Wow.
lecture. I'm the keynote speaker for their Spring Fling conference, 40th anniversary of their Spring Fling conference, doing a couple PEDS lectures there. And then I'll be back in Sandusky, Ohio for the Metro Life Flight Critical Care Symposium, doing it there. And then I'll be at Fast 26 in Austin, Texas in May, presenting it at on the main stage at Fast 26. And I'm super excited to announce that I just signed on with Flightbridge Ed as one of their new instructors.
All
And
right.
I'm going to be traveling the country doing their in-person FPC, CFRN, and CNPT review courses. So I'm super excited for that. I looked up to Eric Bauer and Flight Bridge
Very.
Ed before I even got into the flight
Yeah.
industry. And now I am joining forces with them. And it's so many amazing things are happening. It's unbelievable.
That is so awesome. Congratulations.
Yeah,
Thank you.
congratulations. That's cool.
Yeah,
That is
thank you
So
so
super
where
much.
cool.
can everybody find your content?
Yeah, so I'm on all the social media platforms, Facebook, Instagram, TikTok, Spotify, all those. It's under the Blakery content. And then the podcast is called Reducing the Pucker Factor.
Very cool. So if you had one message to give to everybody to kind of sign it off, that if they heard nothing else about the show, what is that one thing?
I think it's one, stay humble, two, stay open to learning, and three, bad word everyone else, right? F everyone else. Like, just
I love it.
like just be you and just focus on you and do what you want to do and do the things you want to do and just always be open to learning and pursue that knowledge. The extra knowledge will never set you back.
Be true to
Never.
yourself. Knowledge is power. I like that.
Yeah,
Pretty
absolutely.
much. Yeah, I love it. All right.
All right,
Well,
Kevin, where can you find us?
well, you can find us in all the same places you can find Blakery content. So Instagram, Facebook, YouTube, Spotify, Apple Podcasts. What else am I missing? Probably something else. We're all over the place. We highlight our guests a week in advance every week. I keep putting out clips and stuff. We've had a few go really, really viral, which was surprising. But all of our stuff gets really good comments and reviews. And I'm still, and Christopher, you can kind of lead me on this one. I'm still kind of hesitant to go live. I don't know what to say. I don't know what to do. It's kind of one of those things that I'm still like, I don't know. But hopefully we'll get there. We're really excited to continue to see growth. We're really excited to continue to get cool guests like you and like so many others that we've had. I say it almost every show. I'm getting to kind of live a dream too because I'm getting to interview people that I've kind of idolized for a while and been like, man, those guys are it. Those guys are cool. And now I'm getting to talk to them. And the thing that I keep finding over and over is you guys are just regular folks too. Like you're not,
Yeah,
I mean,
absolutely.
Greg Carr, Shade Tree Cardiology said, we're just celebrities with a little C, which is right on board for him.
So I don't know if you know the backstory between me and Shade Tree Cardiology. So my daughter is a congenital heart baby. She's a
Okay.
coarctation of the aorta. She had heart surgery when she was only 10 days old. And then she had another surgery when she was 9 years old. So she had an aortic augmentation where they had to actually do open her chest up and put her on bypass, stop her heart, and put a cadaver patch on her aorta to repair that. So I got to walk her back to the OR because I knew the surgeon, I knew the CRNA, I knew all the staff in the OR. And that
Right.
was her one wish, is that I got to walk her back to the OR. And I physically held her down on the OR table as they were masking her, putting her to sleep, that while she was screaming and crying to me, I don't want it, don't do it. And
That's
it was
horrible.
legit. It was legit the hardest thing I've ever done in my life. Legit the hardest thing I ever done in my life. And I walked out of that OR, again, sobbing. I went straight to the bathroom, locked myself in the bathroom, and my daughter Aubrey, who is fine today, she's phenomenal. We started on TikTok because we were checking off boxes before her surgery. Like legit we don't know what the outcome's going to be, so we're going to do some things that we're a little less comfortable with. And one of the things she wanted to do was be a YouTuber or content creator. So she started making videos up to her surgery describing her whole process. Because I told her, I was like, listen, you could do TikTok, but you're not going to shake your booty. Right. And so she started making videos expressing her journey of this is what a coarctation of the aorta. So if you scroll back to the very beginning of my videos, it's still her explaining a coarc and up to the day of surgery and her recovery afterwards. And this is when the sleepy paramedic and the croissant army and all that stuff was very,
Oh yeah.
yeah. So I locked myself in the bathroom at the children's hospital that I worked at, that my doctor was currently having heart surgery at, or my daughter was having heart surgery at. And made a video and I said, this video is for the sleepy paramedic and the croissant army. I just did the hardest thing I've ever done. And all my daughter wants when she wakes up is positive comments to read, because we would read them every day, each one of them. And the sleepy paramedic took that and just shared it out to everyone. And our Venmo and Cash App was just ching, ching, ching. And comments was nonstop because of the sleepy paramedic. And the Shade Tree Cardiology jumped on and started making a shirt for us and started, EMS talk. And so we connected way back then. So I've followed them way back since the Croissant Army. So I'm a huge fan of Shade Tree Cardiology. And so when he had your video, the video of he had that freezing moment, right? I related to that so much because at that time, I had a burn patient that was the same age and looked identical to my child. And I walked in and I froze for that 0.2 seconds. And then I got it out of my mind and I went to work. So I could relate very much with that sentiment. And I commented on that with Shade Tree. I was like, I know exactly what you mean. So sorry, I know you're trying to wrap it up. I'm a talker. I'm enjoying you guys.
It's okay.
So
that was fantastic.
I'm enjoying you too.
We have so much enjoyed this. I really thank you for joining us.
Yeah.
And of course, you can find us in all the places. Go visit our website, asilentwarwithin.com. You can visit that. There's all kind of resources there for you. One of the things I absolutely love is all the messages that I get every week from different people saying that we've helped them or affected them, or something that we've said or done has resonated. That is the best. That's why I started this. That's why we do this, is so that we can help others. Christopher, thank you for joining us. We are so appreciative for your time. I cannot wait. One of my favorite parts is always the editing phase. I cannot wait to edit this and listen to this back. I think it's been great. But as always, everybody, be safe, take care of your mind, and we will talk soon. See you next time.
Thank you so much. Take care.
You've been listening to A Silent War Within. If this episode resonated, please subscribe, leave a review, and share with someone who needs to hear it. Remember, you're not alone and your well-being matters. It's time to end this silent war.